So now, for those folks who are not interested in biology or this was too complicated anyway, I will show you how this applies for clinical practice, and that's a lot more interesting for you eventually. Next one. So what I wish to basically share with you is the progress in the field. So we have done some intermediate step. We already have improved a lot. We are not there yet, and the next 10, 20 years to come will hopefully change that tremendously. But look at this here, over 30 years. You've seen that fludarabine did a little bit by Dr. Johnston, but the real thing came when we entered in combinations with fludarabine and cyclophosphamide and rituximab and the like. So in 1981, the Binet classification was published, and you see the prognosis on the left side. And the blue curve indicates that if you had an advanced stage, as was shown by Dr. Fraser this morning, prognosis was very poor, around 1 to 3 years in all the different textbooks. The beautiful thing is you can forget about these old textbooks, put them in the waste. They are not containing the correct information anymore. Because now, and this is in our series with more than 2,000 patients just in trials, if you treat them with combinations, you can easily see that Binet stage C is actually identical to Binet stage B, and both have improved. So now the prognosis of these advanced stages, and that's with chemoimmunotherapy only, that's before the addition of the novel agents, which are likely to further improve the prognosis. Now, if you have intermediate or advanced stage, the median survival is longer than 5 years, 6, 7 years, which is a real progress already, and we are really making every effort that this is further improved. The green curve for the initial early stages is a good control, because you see that in the German group, those patients are not treated. Most of them are just watched, and they have a similar, if not identical, prognosis than 30 years ago, basically by just watching the disease initially. We've also developed further scores. This is one that was recently published, just showing you that with modern genetic and biological variables, and they have been presented to you this morning by Dr. Fraser. So that's genetics, the chromosomal analysis by FISH, that is beta-2 microglobulin, that's the age of the patients, the stage. You can define several groups of risk, and there's some patients that are at such a low risk, very low risk, with 0 to 2 points in this classification, that they probably don't need any treatment, because they have a very, very good prognosis, and most of them never require any treatment. That's also an important feature to know. Even if the lymphocytes develop a little bit, they usually are stable over 10, 20 years. And the strong opposite in this purple curve, very high-risk patients, frequently mutated with p53, deletions or dysfunctions need to be treated more aggressively, because their prognosis in the era of chemoimmunotherapy remains poor. But we have become better in predicting which patient belongs to which group if we combine all the novel agents and put them into scores like this. So we are a lot better educated to do this analysis. One additional element to consider before thinking about any therapeutic decision is how fit is the patient. So we classify in our group the patients according to fitness, and that has been pointed out by Dr. Johnston in his talk, into a go-go, so you can do every treatment that is available. Slow-go, you have to think a little bit, and no-go, you have to probably take care of the other diseases and not treat CLL. So no-go, slow-go, go-go, that's based on the fitness assessment that he's just showed you. And these 3 categories have driven the development in the past. I'm predicting, however, that with the novel agents that are less toxic, we have to rethink the concept, because what was too toxic for in the past may not be so toxic anymore if we have all the novel drugs that cause usually not so many side effects, and then therefore this classification or consideration is changing, if not abandoned. We will see. We'll work on this.